Welcome everyone to today's webinar on advances in tendinopathy management and research. We're thrilled to have Professor Peter Malliaras with us, a true pioneer in this field with nearly 3 decades of expertise. Peter is a physio and a clinical research who's genuinely transformed how we approach tendon injuries. His work speaks for itself. Over 120 published papers, including the most cited systematic review on exercise for Achilles and patellar tendinopathy. What makes his research so impactful is that he's challenged long-held beliefs about eccentric exercises and given us solid, evidence-based approaches to exercise intensities. As co-leader of the International Achilles Tendinopathy Consensus Group, he's helped standardize how we diagnose and measure treatment success worldwide. Before we dive in with Peter, let me hand things over to Nick Kane from our partner platform, SportsMap. If you haven't already explored SportsMap, it's definitely worth checking out for quality content at great value. Nick will share a bit about the platform and give us some additional insights about Peter Malliaras. Nick, over to you.
Thanks, Stefania, and thanks everyone for being here, and thanks for having us a part of it. I'm really excited about Peter's lecture. I'm sure you a lot from it. For those who I haven't met before, I'm a sports physio by trade, and I've worked here in Australia at the top tier sport, which is our football level, as a head physio for one of the top teams. I just recently stepped out of that to be full-time in the business. And we're really proud to partner with the NBA Physio Association, and I think it's a great initiative, and we're really excited about building along the journey with you all. And in doing so, I guess part of that is just trying to provide you with some great content, because I know how busy you guys are and on the road. We think it's what we can provide you is some excellent resources available, and we do see it used by really top level physios that might call on a certain masterclass when they're presented with a case. Like Seth O'Neill is a great example. You guys were talking around tendons the other time, and some imaging stuff around the use of UTC and whether that's valuable in prevention and through the course of management. It's a really good one, versus obviously Peter's has one coming out soon on Achilles Tendon Rupture, which is probably an extension of what we might get through today. And what we have there is like an offer for you guys that's much, probably generous, maybe not the right word, but much higher than we'd offer other teams, places, in a sense of a discount, and then the free virtual access. And that's purely just to hopefully get you guys engaged on it, utilizing it. Had some good feedback from those that are using it across the NBA. It's really great to be a part of it, and ultimately just happy to be here as someone you guys can maybe call on and seek some resources and just be a part of your journey around optimizing your athlete management around what you guys do day to day. Yeah, from my end, really proud to be a part of that. And yeah, great to have Peter here from a personal level. Obviously, a great intro from Stefania there. I've used Peter as a consultant for my athletes over many years, from Achilles tendinopathy to patella. And I've probably always found him like one of the best to work with. One, I always walk away definitely learning new things and adding more elements of what I use into my other athletes and around my loading principles. But I guess where he's different is he really has a deep understanding of the tendon physiology and then how to optimize exercise prescription and get the best out of what we want from that. And that's where he steps our way through, whether it's the use of isometrics, eccentrics, and plyometrics, highly practical and really transferable. So that's probably why when Steph and I were talking around who to get, Peter was certainly at the top of the list, and we'll carry on some nice information from your webinar last week. Thanks, Peter. And again, thanks for having us. I'll leave it to you.
Fantastic. Thank you very much. That's very kind of both of you. Thank you for that really kind introduction. I'm really, it's an honor to basically, it's an honor to speak to you guys, given you're sort of working at the top level with these athletes, and it's really, it's a great opportunity. So thanks, Nick, for organizing it, and thank you, Stefania, and the team. So basically I think my background, basically, you guys have covered it, but effectively now a full-time professor at Monash. But one of the things I've really tried to keep up throughout my whole career is the clinical element. So I work 2 days a week at Orthosport Victoria, which is a really good facility. If anyone's ever in Melbourne, it's worthwhile dropping in and visiting. It's a full biomechanical lab, but it's also a place where surgeons, sports doctors, physios, biomechanists work all together. So we do a full suite of outcome measures, biomechanical testing. So they focus primarily on ACL, but now we're setting up a dedicated Achilles rupture service, which will be the same that we do for ACL, but for the Achilles rupture. So if you're ever in in Melbourne, worth checking out. It's a really good facility. So basically, I work there a couple of days a week, and we've also got PhD students that work out of there now. And some of those PhD students are looking at Achilles rupture and trying to improve what we do with Achilles rupture. As I said at the start, very happy for people to ask questions as we go along. So if you just want to yell out, that's absolutely fine. That's good for me because then I know we're covering questions as we go. Just feel free to unmute. We're going to go through and try and get through a bit about, and I'm not going to probably go into detail with some bits because I think you guys will be well aware of things like, for example, impact and mechanisms, and probably also management approaches and some of the problems that we see with Achilles rupture. So I'll probably try and focus it on what I see are the key elements of rehabilitation to try and hit when we've got someone with an Achilles rupture. I've also got a little bit of sports trivia in there, but they'll be very easy for you guys, these questions. We know, and this is sort of my interest in Achilles rupture, I've always consulted to tendinopathy, mainly Achilles and patella, but probably over the last decade have just the people, because they saw that I specialize in Achilles, tend to then refer me Achilles rupture as well. But I often would see the ones that had failed management beyond, say, 16 weeks were not able to do a calf raise. And I really started to enjoy that challenge. So then I started talking to surgeons more, getting involved in the earlier end of the spectrum. So then it's grown over the last decade into a real focus of what I do now from a clinical point of view. So I do get asked to input into some of the more high profile ones around Australia and sometimes internationally as well in terms of rehab. And that often is just speaking to the clubs about things that they could do. We know that it's an injury that everyone really wants to try and prevent. And we can talk about prevention later on because it's such a catastrophic injury. And it happens, as you guys would know very well, at the end of someone's career most commonly. You do see it in 17, 18, 20-year-olds, but most likely you're going to see it near the end of their career. And that's why the return to sport competition stats are so bad because people are older and it's a tough injury to overcome at that age. So it is something that really does affect people, and there's a lot of fear involved with it because they're fearful that it's going to happen again and they're going to have a rupture of that same tendon. This is the first bit of sports trivia. I'm sure I don't have to tell you guys. This is Kevin Durant from the 2019 playoffs where he ruptures Achilles. But just looking at this, it's just such a typical mechanism, and it's not anything that the player hasn't done 1,000 times before. Very similar to Jason Tatum the other week, just stepping back, pushing off. It was quite identical, actually. It's funny how similar those two are. But it is a submaximal event. It's not a maximal event. It does happen, obviously, landing and jumping and things like that. But a lot of them happen just like that, where they're just doing a submaximal step back. What is actually happening when this happens? It's not just about exceeding the force that the tendon can take, because the tendon's strong. We know the Achilles is the strongest tendon in the body. There's a massive element of tissue fatigue that also is part of the problem of Achilles rupture. So this is a tip of the iceberg type problem where fatigue of the tissue over multiple strain episodes is occurring, and it can happen with something quite benign and submaximal. So that's what we generally see across all sports. It doesn't have to be a maximal event, okay? And people can rupture for no reason or for no apparent high load reason. So that's important to keep in mind. It's always fast dorsiflexion, so moving into dorsiflexion really quickly. It can be eccentric or concentric. So just that mechanism of moving into dorsiflexion where the tendon is strained, that's what it takes. It takes a lot of tendon strain. There's also some thinking to say that if you do something slower, you're more likely to get a rupture because the tendon is viscoelastic. And if you stretch it fast, it bounces back quickly. Whereas if you stretch it slow, it actually does become much more compliant. So slow activities bad, or when I say slow, I don't mean like doing a slow stretch, but doing something like a step back a little bit slower than you usually would, or not at maximal effort, is more likely to lead to more strain. In terms of the mechanisms, the tendon is really a stiff and strong structure, but when we're doing sports activities like jumping, cutting, step backs, the muscle becomes stiffer. And that's really important to understand. The muscle is stiffer than the tendon during stretch shorten cycle because it is the thing that's driving tendon elasticity. So generally, strength could be a risk factor. You could say that strength of the muscle could be a risk factor for tendon injury, but certainly elasticity in the tendon is a risk factor. Athletes that are elastic, and we know that we think about athletes in different ways, we profile them, but the ones that are more elastic, the ones that are able to utilize elasticity in their tendons very well, they tend to be the ones who will be more likely to have fatigue of that tissue over time. So that's an important consideration as well. So if you look at, this is data about the incidence. So if you look at, this is Achilles rupture and this is tendinopathy. If you look at the sports where it really does occur quite commonly, you're looking at sprinting and you're looking at things like decathlon where they're doing lots of running, but you're also looking at basketball. Okay, basketball's, it's up there for sure. And because so many people play basketball, it's one of the most common sources of injury for us in terms of Achilles rupture. So I won't go into this in detail because I know this is probably stuff that was talked about last time when you had the surgeon talking, but we generally have that decision of whether we're going to do surgery or non-surgical. A lot of the times it depends on factors like this, where if we have someone who really is not a surgical candidate, then that decision is a bit easier because you're not going to go down a track of having surgery. So in our rupture service at Orthosport, we see pretty much the full spectrum. Like for example, seeing at the moment a diabetic who has ruptured his Achilles tendon, and he is not a surgical candidate for that reason, but he's also had amputation of some of his toes on that same foot. Really challenging demographic to work with. But they're the types of people that are probably not going to have surgery. But we know for most of our athletes, they're going to go on to have surgery, and that's going to be the pathway for them. We'll talk about the benefits and the harms of surgery versus non-surgical in a second. It also depends about where the rupture is. So ruptures occur at 3 points. They occur in the mid portion of the tendon. They occur at the muscle tendon junction. So that's not really a tendon rupture. That's a muscle tendon junction injury, but they do rupture completely there as well. And they tend not to have surgery, the muscle tendon junction, if it's a true muscle tendon junction rupture. The other thing that happens is you get rupture of the insertion. That with the muscle tendon junction are less common than the mid portion ruptures. These are the least common, but they're going to be managed in a different way. Ones we're focusing on today is the mid portion Achilles rupture, which is the most common ones that we see. This is a really useful patient decision aid that has been out for a few years now, just looking at what are the pros and cons of non-surgical versus surgical treatment for Achilles tendon rupture. And we can see that when we have surgery, re-rupture rates are lower. And when we have non-surgical treatments, surgical complications are lower. And that makes sense. So things like deep infection and nerve injuries are lower. The key point that I make to patients though about this, because we probably see about, in our clinic, we see about 50-50 of people that go for rupture or go for surgery versus non-surgery. And the outcomes seem to be quite similar. It doesn't seem to be a big difference in terms of outcome. The thing that I stress to patients is that re-rupture rates are low, regardless of whether you have surgery or not. They're very low. It's very different to ACL, where ACL re-rupture rates are very high. So you're talking in the 20%, whereas with with Achilles rupture, you're talking about 2 to 4% rupture rate. So it's very small. So it's not a big difference, even though surgery does reduce the rupture rate. It's a small difference, okay? And that's the key message for patients. The thing that is the biggest problem, and that we're going to focus on a bit more today, is elongation. So re-rupture is not so much a problem because it's not that common, but elongation is a massive problem when it comes to Achilles rupture. And that's the thing that really slows people down. And that's the thing that prevents them from going back to sport, because they just cannot get the power they used to have if they're elongated. So that's a real priority, to try and reduce the level of elongation that people get. So talking about these issues that happen in a little bit more detail, if you're thinking about re-rupture, it's generally going to occur in the start of the rehab period. So where people re-rupture is generally when you've got someone who is not adhering to the advice. So taking their boot off, walking without their boots, taking their boot off at night, all those things. That's going to be a risk of re-rupture. So generally getting them into dorsiflexion too early, that's a risk of re-rupture, especially when you involve speed and eccentric contraction. So obviously that's something that we want to avoid in those really early periods until they're tolerant. So that's important. The other key period where they rupture is when they first come out of the boot, because what generally will happen is people will be in the boot for a long time, 8 weeks, 12 weeks, and then they'll get out of the boot and they think, well, this is finished, we're done. We can just carry on and go back to walking as normal. But as we know, it takes a long time to really recover that strength, which we'll talk about. The other problem is elongation. We know that at some period during that rehabilitation, people get elongated. And the sad thing at the moment is that pretty much everyone gets elongated. So you don't escape elongation with an Achilles rupture. Everyone gets it. It's just the amount of elongation that you're going to get. What happens with elongation is the tendon part becomes longer and the muscle part becomes shorter. The muscle tendon unit length is the same. So the whole unit length is not changed. It's just that the muscle is shorter, the tendon's longer. And that just puts out of whack the whole architecture of the calf Achilles complex, because you've got fascicles that are not functioning the way they should be anymore. You've got lack of elasticity in the tendon and a lack of ability to absorb further loading into stretch. So it really puts out of whack the ability of the tendon to act as it does. And that really then impacts on performance. Okay, so that's a real problem that we face with people.
Peter, sorry, can I ask, is the elongation assumed to happen over time, or is it assumed it's possible in the surgical technique as it is?
Yeah, that's a really great question. And we know that one of my pediatricians is doing a review on this at the moment. It happens throughout the whole rehabilitation period. So elongation can happen at surgery. So we know there's evidence that people are basically then put into a position that is elongated, but it can also happen during the boot immobilization period. And then it can happen after the boot, when they come out of the boot and they start walking. It can happen right up to 12 months. So the thing to think about with the tendon is it's just a malleable scar. And it basically, you've got these two tendon ends and there's just this scar, and it will just change like that throughout the whole rehabilitation period. So we see that sometimes I see them elongated at 12 weeks, and that actually then reduces at 16 or 24 weeks if you do the right things. So elongation is a very plastic type of process, and it can go one way or the other depending on the things that you do. Okay. Does that answer your question?
Yeah, and to measure that, is that based on the foot position, or do you measure it via ultrasound?
In our clinic at OSVI, we do both. So I do a direct measure I do a direct measure of the muscle tendon junction of the gastroc to the calcaneum, and we track that every single time we see the person. We also do the resting angle or Maddle's test, it's also called, which is this one, where you're measuring just the angle, and that's fine. That as an indirect measure, that's absolutely fine. That does give you, but the problem with that indirect measure is it will vary a bit depending on resting tone in the calf. So this is more variable. So if you measure the Maddle's test over time, what you find is that it's quite variable. So even in the good foot, they can go from 15 to 20 degrees over a week or two. It just depends on what they've done. So it's a bit more variable. Okay. Any other questions on that? I'll just pause for a second.
I just had another question around this piece. So you'd said that the elongation can change and ebb and flow up to that 12-month mark. Is there any time frame within that where it's less likely to recover? Do you understand what I mean?
Yeah, that's a good question. It generally, after 16 weeks, it becomes really hard to recover. So 16 to 20 weeks, the tendon becomes stiffer. So the material starts to really form as a tendon. It is harder to then make those changes in the right direction. You can go in the wrong direction and keep going in that direction because that's where gravity wants to take the tendon, wants to take it to being longer. But to go in a shortened direction, it's very hard to reverse, I find, after those first 4 weeks out of the boot. Yeah, can be tricky. Okay. So fantastic. So just keep asking questions as we go along, if there are any. Okay, just a case study then on elongation. So this is a basketball player that I saw who was he was quite a high-level basketball player initially. Then he was playing at a low level, ruptured his Achilles tendon in his early 30s, and then had a really, really difficult year and a half with it. Initially, it was repaired, then it got an infection and got a re-rupture. Then he went to another surgeon, got it re-repaired, and then he got another re-rupture after that. And then went to a third surgeon who said, don't repair it again, just a non-surgical treatment, and you're probably never going to be able to walk without a limp. And this guy was devastated because he wanted to obviously not only play basketball, but run around with his kids. And he ended up, he had stacks of elongation, but we did a rehab protocol with him that went on for about 12 months. And he ended up getting a really good outcome to the point where his elongation reversed, similar to what we're talking about. And he was also able to go back to basketball and didn't walk with a limp, etc. So I am a real firm believer in just the right type of loading over the right amount of time can get a really good outcome, even with people who are really struggling. One of the sad things about this story is that he went back to basketball and then 2 months later, he ruptured his other side, which does happen as well. But now he's recovered from that, which is good. Okay, surgery versus non-surgery. So one of the things that people use to guide whether you go surgery versus non-surgery is ultrasound. And I'm not sure where I sit with this. I don't think it is a very good practice because if you go back to cases like Jace, he basically would be someone that they would predict as this guy's going to get elongated because he's got a bit of a gap. But you can, as I'm saying, with sort of the experience we have in our clinic, I think you can peg the gap back and you can make it a better tissue because it's so malleable. I think it's more malleable than what we give it credit for. And I think the rehab that we do is the most important thing. So my view is that we focus on the rehab after rather than worrying too much about how much gap there is initially. And that's pretty much the message from the literature as well. There's a recent Copenhagen Achilles rupture treatment algorithm. And this is a really good study where they've looked at trying to decide whether they have surgery based on ultrasound. And they found pretty much that it didn't make a difference. Whether you did guide it based on ultrasound gap or not, didn't really make a difference. So that sort of supports that view. So let's get on to rehabilitation then. I'm conscious of time and I do want to cover this. So we know that rehab has changed a lot over the years. This is from 1968. And what they would do then is put it in a cast for 12 weeks and just leave it. They'd do an open repair to start with and then just put it in a cast. That's what we used to do decades ago. And then it's gone to this, which is accelerated. And accelerated, as we know, is the thing that most people would adhere to more so now. And the idea with accelerated was that we need to get people out of the boot. We need to get people moving a bit faster. We need to get things going. We need to wean them off the boot. We need to get them walking faster, and that might have a positive effect on their muscle strength, their recovery, and also outcomes like elongation, which we're talking about. So that was the hope with all these accelerated programs. So that since probably the Willits program, which has been around now for a good 15, 20 years, that was what we have really gravitated towards as a management post-surgery or post-non-surgical care for Achilles rupture. The unfortunate thing is, though, that it hasn't really changed a lot of the outcomes that we're hoping it was going to change. So if you look at things like tendon elongation, you look at things like return to sport times, re-rupture rates, it hasn't, there's lots of trials now looking at comparing these two types of approaches, and there's not really a lot of difference in what people then come back at. And for me, the biggest one is elongation. So we've spent a fair bit of time over the last year and a half, developing a protocol at OSVI, which is targeted towards elongation and elongation is the gateway, we believe, to return to sport and also to things like performance, because that's the thing that is really going to slow people down. So that's what I'll talk about in a second. So basically, we know that the stiffness of the tendon is also something that we need to think about. How can we optimize the strength of the tendon? That's one of the key things that we focus on, because we know, and this is just a stress strain curve or elongation force curve, and it just shows you that these people with Achilles rupture, their tendon's more compliant and it's just stretching more at lower load. And that's going to be a real problem for elongation when we start to load the tendon. So just thinking about how can we strengthen the tendon without necessarily leading to elongation is the key thing that we've tried to think about with our protocol. So this is what we think about as some of the key targets of an accelerated program. They're weight bearing pretty quickly. Obviously, they're immobilized for a certain number of weeks. Usually it's about 6 to 12 weeks. I think the average is probably coming out of the boot at about 8 weeks. Immobilization position, usually it's quite high initially, and then we're dropping down with the wedges as we go. Exercise whilst in the boot. There's not a lot from the literature about this in terms of what people do. Most people would do some sort of loading in the boot, but it tends to be quite minimal. And the walking advice is also not very clear. And there's also no criteria. We don't use criteria. So if you think about ACL, a lot of it is criteria based these days, whereas in Achilles rupture, you'll get the surgeon's protocol. And I don't know about you guys, but most people in Australia won't even worry about that because we are going to be using our PT brains and using criteria anyway. But most of the surgeon's protocols are all based on time. So I think the thing that we've tried to improve with what we do now is thinking about these key factors, which I'm going to talk about now briefly. So the heel wedge is a consideration. The wedge does make a difference to how much dorsiflexion. Vacaped is obviously the industry standard if we can get people into that. The Vacaped boot, this is a study showing how much force there was, estimated force in the Achilles tendon. And with the Vacaped boot, there tends to be good control of Achilles tendon forces in that push-off during gait. Not too bad with some of the other ones, like the Air Cam and the Air Select walkers. We still use these boots. I don't think there's a huge difference between the boots as long as they're using the boot and they're in the appropriate wedges. Obviously, the Vacaped is going to assure that you're in the right type of range of motion. So The thing that I think is really important to appreciate, and this is the thing that our protocol is really underpinned by, is how much force is going through the tendon at any one time. So when we're walking in this Vacaped boot, we're getting about, let's say you're in even one of the other boots, you're getting 1 times body weight going through the tendon. So in this period here, so if we break it up into walking out of the boot, this is when they've first been repaired, where the suture can take a little bit of strain, maybe up to about 50 kilos. In this period here, the tendon is really malleable and we need to protect it. Yet we're getting them to walk in a Vacaped boot or whatever boot with about half their body weight going through the tendon. And that could be 50 kilos or it could be more. So I think what we've really got to think about here is how can we optimize the strength of the tendon? And then here in this phase where we're coming out of the boot, we've got to think about how can we get them ready for full weight bearing, where they're going to be taking 320 kilos of load through their Achilles tendon. And what we're doing at the moment is nowhere near enough to get them ready for that transition, regardless of accelerated rehab, walking early, etc. Okay. So my thinking, and we'll talk about that in a second, is we need to be able to think about the force going through the Achilles tendon when we're doing loading within the boot period. This is a study where they've modeled the amount of load in body weights here with different exercises. And this line here that I've highlighted is 50%, added an additional 50% of body weight. And you can see that when you go here to about 20 degrees of plantar flexion, they're getting about 1.5 times body weight going through. Okay. And that's going to get you somewhere in the vicinity of what you need for walking here. So that's an important thing to think about. Okay. When we're starting to do loading, at what level are we happy for people to start walking? So I'll just put some more detail to that as we go through. The other thing that I think we need to rethink, and we do this in our protocol, is when the boot is removed. I don't think it's a good idea to remove the boot at 8 weeks unless you've developed the strength in the tendons to tolerate walking. So our protocol is based on predicted load in the Achilles tendon, predicted load in walking, and how much gap there is between those when we remove the boot. We're generally removing the boot at about 11 to 12 weeks with most people, rather than the 8 weeks. But what we do more of in our protocol is very aggressive loading when they're in the boot. So we load into safe positions, and it's usually into plantar flexion. And a lot of it is in seated, but they also progress into standing, as we'll talk about in a second. And we try and get them to the point where they can do a standing calf raise pretty much with one leg whilst they're in the boot in plantar flexion. And that's an isometric where they're holding. Okay. So that getting to the point where they can hold their body weight, a good aspirational target. A lot of the elite people we see do get to that level. It does become a bit tricky when you've got, say, 120 kilo rugby prop. Getting to 120 kilos is quite challenging, but most of them will get close to that level. And that's a really good marker. The other thing that's important is walking advice when they remove the boot. As I mentioned earlier, you can still get that elongation happening all the way through into that first few weeks when they're walking. So protected walking, where they're using a heel wedge, they're using reduced step length, so a step 2 gait on their unaffected side, partial weight bearing, especially if they're limping. So if they've got a limp, they're not able to push off, getting them still to partial weight bear for a period afterwards. So we do as much as we can to try and protect that healing Achilles tendon until it's developed the strength that it needs. So I guess the summary of our protocol is we're a lot more aggressive with loading early in safe positions, but we're a lot more cautious with immobilization time. So when they get out of the boot, and we're a lot more cautious with things like heel wedge removal, timing of those things, because the key factor for elongation is going to be what position this healing tendon is in. And if you're removing the wedges sooner, you're going to be stressing that into an elongated position sooner. So our view is, as long as you're doing the aggressive loading to strengthen, load the tendon, load the muscle, you can be a lot more relaxed about these other things, which we call accelerated rehab generally. So this is the protocol then, and I'll just talk you through this. So this is probably the key thing to discuss. So basically we've got a few periods. The first period is the immobilized period. So this is when they're in the boot, and these are just approximate timeframes. So what we're doing a lot of in that initial immobilization period, people are doing a lot of seated calf raise, seated isometric calf holding. So they're holding weight in a plantar flex position. We generally start this at around about week 2 or 3. So week 2, they'll come out of the boot and they'll just get used to just with body weight, just with leg weight, being able to push through their big toe and lift their heel. Then by week 3, we start to add load. And initially it might be 10 kilos or 15 kilos put onto their knee. And then throughout the rehab period, they're trying to get up to 0.8 to 1 times body weight through their knee. Now, because that body weight is being applied through the lever of the foot, if you work out the internal forces on the Achilles tendon, they're actually much higher. So the internal forces of the Achilles tendon goes to about 2 times body weight if we achieve this. Okay. And that will depend on the individual. So we work out their foot length, and we also work out their Achilles momentum so we can predict the internal forces within that Achilles tendon. And that then guides how we progress them with their walking. It also guides how we progress them with their boot removal. Okay, so this is a really important outcome for us in terms of trying to get them to a point where they've got the tendon strength to cope with walking. The other thing we're doing in that initial period when they're still in the boot, we try and get them into standing. So the standing will happen at about 8 to 10 weeks. So once they're starting to be able to hold about half their body weight in the seated calf raise, then we start to get them into standing, do similar isometric holds in standing. And this is just similar to this that I showed you here before. So initially, obviously with 2 feet, this is here for safety, just to make sure that they don't collapse into a dorsiflex position. So the other thing is strict immobilization whilst they're in that boot. The second period, so the second phase, approximately 6 weeks, is the initial post-immobilization period. So post-immobilization, where our target is to get them to do a single leg calf raise and to do a few single leg calf raises. So if they can do 15 bodyweight calf raises on single leg, and this is all on flat ground at this point, that is a good target for us in that initial 6 weeks after. We're doing in this period, we're doing a lot of single leg seated isotonic and isometric calf raises. So we're doing both isotonic and isometric now. We're training balance. So they're doing lots of standing on one leg, balance drills, gait drills. They're doing work on their unaffected leg, all the rehab for their unaffected leg. We're doing some double to single leg standing progressions, which are isotonic, and would also do some isometric progressions in single leg standing. So we're working the calf in many different ways. The other outcome in this stage is a 1.4 body weights MVIC, and we'd do that in a seated position. So like this, so using the Veld force plates in a seated position, not quite like this, or using the force frame as an alternative. This one here is in dorsiflexion. So this is a bit too extreme for that stage. So in this initial post-immobilization period, what we're aiming for is plantar grade, okay? So pushing maximal force in plantar grade and building that up gradually. We're also putting in some pushing isometrics at this point, not only the holding isometrics, to make sure that they get used to activating their nervous system actively and they get better at this type of task. Okay. So they're targeting 1.4 times their body weight. The other thing we target is 1.2 times their body weight in this seated isotonic. Okay. At this point. So there are our targets for stage 2. They're still doing a protected gait at this point. That's going to wean to unprotected gait during this period. Okay. In the third period, this is where they're starting to build capacity on single leg. So here we're doing things like single leg standing and seated isotonic, and we're really progressing the load now with this. So we're really starting to also bring in dorsiflexion. So the way we bring in dorsiflexion, let's see if I've got a picture of it, is using plates. So we'd use a 10 kilo plate, which is about 1 inch, and we'd start dorsiflexion over that. And then we'd use 1.5 inch plate and start over that. And then we'd go to this sort of 2-inch plate and start with that. So progressively building in dorsiflexion in this third stage is really important. And that takes the place of any flexibility work, because they can do that in a knee bent and a knee straight position, and that will then sort out their flexibility. So we don't tend to do any stretching per se, because it will come as they do that full range dorsiflexion loaded. They can progress to sled work as they're getting towards their isotonic targets. So here we're wanting 2 toes body weight in a plantar flexed isometric MBIC. Plantar flexion isometric in plantar again. So same test as here, but just progressing to 2 toes body weight. And we also track things like the height of the heel. So we use for that a linear encoder. So this is just a linear encoder. Basically just tells you the centimeters and also tells you the velocity. But we can track how high their heel is getting with that, with their calf raises. So when they're doing calf raises, we would have that on and track that. And that gives us this leg symmetry index in terms of side to side. We're looking at knee to wall and seeing that they're recovering that knee to wall. Doesn't tend to be a problem though. Most people will recover their flexibility, will just come naturally as they start to do all this stuff here. The other thing we do in this stage is gait prep. So hip and ankle focused gait drills, and we do some plyometric prep. So plyometric prep would be things like getting used to some very low intensity decelerations. So it could be just initially just falling forward and stopping. It could be landing double leg from a very small 15 centimeter box. It could be jumping onto a very small box, could be just some squat jumps or just something really low intensity, double leg, just to get them used to starting to absorb forces and generate force. And then the last stage is more about power. So here we're doing force generation. So this is where we're progressing jumping. So now they're doing jumping on single leg onto boxes. They could be then progressing that to things like maximal step up jumps, maximal Bulgarian jumps, things like that. Then they're doing a hopping progression. So they're starting submaximal hopping, double leg to single leg. Then they're going maximal pogo progression, single leg. They're also doing any sport specific. So depending on their background, depending on their sport, high speed running, deceleration, higher intensity deceleration and cutting. So that's an overview of what we do. And then we've got the outcome measures here. We'll look at maximal counter movement jump. We'll look at things like maximal hopping for distance, 5, 10 and drop jump with the valve force plates. So that's what we're trying to look at. The other thing I tend to look at a fair bit is just their calf muscle power profiles. This is now using the linear encoder again. So with the linear encoder, we're getting them to just go down and then explode up as fast as they can, and then slightly down again and then explode up as fast as they can. So it's really a measure of concentric intent and speed. And we know that if you put 6 RM load on someone, they should be able to get to above 0.5 meters per second. as a mean peak velocity. So that's what we aim for when they're recovering, just to get their power back. So that's another thing that we look at. Yeah, so that basically covers it. The only other thing, we've talked about the measures of the length of the tendon. So this is how we do it. We just mark on the skin and we measure that directly with a tape measure over. I talked about the Achilles tendon resting angle. And I think we've covered most of these. These are the targets. So say, for example, with a yielding isometric in standing, if you've got a athlete, you'd want to be getting them up to around about their body weight on the bar. So that's a good target for us. Body weight on the bar in a dorsiflex position. In a plantar flex position, they're going to be a bit weaker, and that would be a bit less. The other thing that's really key to say about all this rehab is we often split the isometrics and they do two different positions, because we know that they really need to recover that inner range strength into plantar flexion. So we'd often split the isometrics and they do lots of isometrics at the top, and then that do some in the middle or just in a slight amount of dorsiflexion. And that lower position is much easier for them, so they can progress much faster. Whereas the higher position is a bit of a struggle, but it's important to keep that in so they're recovering that inner range strength as well. So we tend to split the isometrics in that way. These are just some tips for recovering strength when you are at that real early stage. So one of the transitions, and this happens in that stage, this happens in stage 2, where we're still potentially having someone who is struggling to get to their body weight, or it could even be in that immobilization period where we'd use scales, and then we'd use a step here at the back, and they're doing a isometric hold in a plantar-grade position, but they're using part of their body weight in the scales in front. And the scales just tells you how much of their body weight they're able to hold. It could be that they've got 80% of their body weight on their loaded leg, and then we're trying to progress that towards full body weight. It just gives them a little bit of feedback in terms of where they need to be. The other last thing that I'd say, and then maybe we can have some discussion and comments, is we try, and the amount of isometric dorsiflexion that we're loading in is in parallel to the boot removal. So as we're removing wedges from the boot, we start to go into more dorsiflexion with their rehab. Okay? So that's what we do. We try and line those two things out. So that happens particularly in this phase here. So as we're removing wedges, they go down. But we tend to remove the wedges quite late. So instead of, say, 4, 6, and 8 weeks, we would probably remove the first wedges at 6 to 7 weeks, and then at about 8 to 9, and then at about 10 to 11. So we tend to delay that, again, just to try and minimize the risk of elongation. Rightio. So look, I'll probably pause there, and it'd be really great to get some questions if people have questions. But I've got a couple of other things, because Nick told me there was also some questions about preventing ruptures, but so I chucked a slide in about that. But if there's anything else that people have questions about, happy to answer those.
Hi, Peter. Amy here. This is fantastic so far. Thank you very much. Just a quick kind of silly question. I've been in and out. The slide that you had that you've been talking about, your rehab protocol, each row where it says plus 6 weeks, is that 6 weeks from the previous row?
That is, yeah. So if you add it up, it's going to be 18 weeks to there, and then it would be, that's 18 weeks. Then that would be 24, and then you've got this part here where you're developing further. Now that can be faster, and that's an indication that can be faster. I think return to sport, obviously, if we look at the elite people, I'm involved at the moment with a couple of elite people return to sport here in Australia, and they've got targets of return to sport in 6 months or something like that, which is ambitious. And I think probably not something I'd recommend as a target. I tend to recommend more 7 to 8 months for an elite person is realistic. So this can be compressed, and that's what we'll do for elite people. But I think you do have to respect the healing of the tendon as well. And it really does depend on how this initial part goes, I think. Yeah. So it is something that can be modified. What's experience from you guys in terms of what's the NBA standard for return to sport? Months wise.
12 months for Achilles repair.
Yeah. And that's sensible. I think that's sensible. Yeah.
Thank you.
No problem. No problem.
Peter, just on that note of that slide, in those early phases when they're doing the isometrics, say phase 1 and phase 2, are they out of the boot and then they're only in the boot for absolutely everything else? But for the
Yes.
isometrics, they're out of the boot with safety.
Yeah, exactly. Yeah, they're out of the boot for the isometrics. So we take them out of the boot. For example, they'll come in when we're assessing them. I tend to see them every 2 weeks in that initial period. And when I'm assessing them and seeing them, they'll walk to the Smith machine with their boot on. They'll take their boot off. They'll do all their rehab with their boot off, and then they go back into their boot. So they've got the boot on the whole time. And we set them up in a safe way because obviously doing aggressive loading early on is a risk as well. So the surgeons that we work with, they are on board now, but they also had a few raised eyebrows initially about what we're doing, but they are on board now completely with what we're doing. So it's about, I think, just making sure that they're always in that safe position. Because no one's going to re-rupture their Achilles in plantarflexion. It's just not going to happen. So if you can ensure they're in plantarflexion, you can load them safely, which is really good.
I have a couple questions for you. How early through this process are you starting to introduce even intrinsic muscle activation of the foot?
Yeah, that's a good question. He's going to be up here in this immobilization period. So we would do things like toe spreading, would do things like short foot exercises, just to get their proprioception, because they've got this foot that's swollen and they just don't have any awareness because they've just been in a cast or in a boot for 2 weeks and not weight bearing.
Mm-hmm.
So it just feels strange for them to put their foot down.
Right.
So we incorporate that at 2 weeks in here. Yeah. They'll stamp that as well. Yeah.
Your single leg capacity phase in the third row, what does your running progression look like? Where are you starting on an Ultra G? How much are you running them? What kind of intervals? Can you break that down a little bit?
Yeah, sure. Running is safe to do. Our cutoff or our criterion for running is when they're starting to achieve some of these targets here. So when they're approaching these targets, we start them with a very slow shuffle and they'll start to just run on flat, slow, straight onto flat ground. Not the Ultra G. Some clubs that we work with, they will use the Ultra G, but that's not part of our protocol. And I think it doesn't, in my opinion, it doesn't really save you a lot of time or add a lot of extra running in earlier on. And I worry a bit about the risk of running with the Ultra G, even with modified body weight early on from a tendon elongation point of view. So the way that we tend to look at it is as soon as they hit their targets or they're getting close to those targets, start with a small shuffle. And that could be at the start of this period here, they'll commence a little bit of running. And it might be 2 to 3 times per week on their usual training days. They'll incorporate that. So they might be doing at that point, they might be doing some isometric work. Then they might be doing their run, and they might also be doing their plyo prep work before their run. So then it's like a bit of a training block. And then that's just built in terms of volume initially. So we build the volume of their running. And then once they're starting to get towards these targets, where they're starting to feel like they're pushing a lot more force. They've got a lot more strength in their tendon. Then towards the end of this stage, we can start progressing the intensity of their running. And particularly in this stage here, where we start to progress the intensity of their running. Yeah, so that's how we go with it, with the running progressions.
I have one more question for you, and it's related to the video that you showed of the athlete that tore his Achilles. His Achilles was exceptionally long, like it was a very like short condensed gastroc and a very long Achilles. How do you look at someone with a leg like that versus a more stout kind of hockey player with, are you looking at those differently? Are you treating them any differently through the course of your rehab?
It's a great question. You mean Kevin Durant?
Yes.
Yeah. So basically it's interesting. I'm fascinated by the anatomy of the calf and the Achilles and how that interplays with what is happening. I think Kevin Durant, obviously he's got, and most people, the length of the Achilles tendon influences how it functions. So these people will be straining that Achilles tendon a lot more during their day-to-day life because it's more compliant structure because it's longer. So it's that fatigue, it's that accumulation of loading, which I think is relevant. So that would factor into the rehab because you would want to make sure that someone like that, not only you're preventing elongation, but you're also making sure that he's got a lot of fatigue resistance and a lot of strength and stiffness in that Achilles tendon. And it was what I was talking about earlier with the profile of the athletes. I think some of them, that springy, elastic type athlete where they utilize this stretch, shorten cycle mechanism very well. And that can be a problem for them. So it would be a really interesting thing to look at. And that is basketball injuries. Obviously in the NBA has been a stack recently, but looking at the profile of athletes that we're seeing these injuries in, I don't know if that has been done before in the NBA, but that would be really interesting to look at. And that would include looking at the calf and tendon complex and size. The other thing that's really critical, and I'll just bring it up now, is because Nick did warn me about these questions, which is about, can you prevent an Achilles rupture? And I think people do use UTC and people do use things like that to look at the structure of the tendon and get a really good idea of how good the tissue is. And that's a good indication. But we also know that rupture is not just about pathology. What a UTC picks up is change in tendon integrity or structural pathology. But what we also know is that tendons rupture when they're weak, not just when they're pathological. So this is a guy that I saw in the clinic who unfortunately was someone who I was seeing for a Achilles tendon pain problem on the other side. And so I ultrasounded both of his Achilles tendons. And then the next week when I saw him, I was doing some hopping plyometric progressions for his painful Achilles tendon, and he ruptured his non-painful one in the clinic when I was working with him. So then, of course, I put him straight onto the bed and ultrasounded him. And this is what we saw. We saw a really fresh Achilles tendon rupture. But this guy before the rupture, his tendon on ultrasound looked healthy. So the mantra that we have that normal tendon does not rupture is, I think, based on a study that is very biased. And that was the Canis study from 1997, where they had 1,000 people rocking up to hospital. Of course, they're going to be the more severe end of the spectrum, but some people with a seemingly healthy looking tendon will rupture. So can you prevent based on imaging? I don't think so. What you need to do is measure the stiffness of the tendon. So this is what we're working on now with our PhD students. We're trying to work out ways to measure how much tendon strains for a given amount of force that you put into it. And these measures are available and we do them all the time, but they're very much lab measures. But if we can use that as a screening measure in a sports context, that would be really helpful. And that would be something that could prevent injuries if we see someone who is quite strong and produces lots of force, but has a really compliant tendon. And that's the thing that you're going to be looking for to try and intervene on that and bring about some tendon stiffness. So that's what we're working on at the moment, to see if there's any preventative element to that. So that could be a really good study that we do have an association here with basketball clubs here. So we're looking to try and run something like that once we sort out these measures. But it could also be something that we do overseas as well, if there is interest in something like that. Yeah, so it's hard with imaging, I think, to actually know that you're preventing these injuries, but it does give you a clue. What do people use in clubs here? In your clubs, do you use anything in terms of imaging for that ability to look at the tendon and see if it's going to potentially be a problem?
I think if a few teams utilize UTC, but more commonly it would just be standard ultrasound and MRI imaging, of course. But I think a lot more teams are using ultrasound in-house. And then there's a bit of dabbling with elastography. So what do you guys use for that? Because that's the tricky thing. Like even our expensive Canon doesn't have the frequency to meet the stiffness of these tendons.
Yeah, we do use elastography in our research. So we've got a really good elastography machine that we use. We don't have UTC, but we are going to acquire one for this study that I'm talking about. And what we want to show is we want to try and look at all the different types of tendon measures, because UTC basically gives you a stiffness at a specific region. So it'll give you a little region of the tendon. You can see how stiff it is. It's a tough one because you have to then map the tendon all the way up and down because you don't know where it's going to rupture. So I think overall strain of the tendon, which is what we're looking at, could be an easier measure. UTC could be useful. Ultrasound itself could be useful, but we just don't know at this point. So I think what we need to do is look at these measures and see which ones, if any, are predictive of rupture. So that's the next step.
I wonder if anyone in the group here has experience with any imaging pre-post rupture with any athletes, or anyone have experience with UTC as well?
Yeah, I'll just mention that we have used UTCs, but what you just mentioned, it's specific to that level. So if you're scanning at the free tendon level, the tear can happen proximal to that, and it's uncertain whether that pathology was at the site of the injury or not, and whether that's predictive or not, it's hard to tell. But I thought Peter made a good point about how the scans show the pathology, but it doesn't show the capacity. And I think foundationally, it's a good point to understand that tears happen when the capacity exceeds, or the load exceeds the capacity, or it's too weak.
Yeah, exactly right. Yeah, couldn't agree more. It's really important to differentiate those two things, especially in a sporting context where you're getting a lot of high forces. So it's not just about, and these players are young. So, they're young in inverted commas compared to some of the ones I see in their 50s and 60s that rupture. They always have pathology because they're of that age, where they've built it up over time anyway. Whereas these young people, they can rupture without a lot of pathology there. That's my thinking, but it'd be really interesting to see if anyone's got pre-scans of players that have ruptured. I'd be very interested in seeing those or learning more about that, because that's what we're seeing, that some players don't have the real extensive pathology you might expect when they rupture.
I know Dr. O'Malley last week was very keen to do some research as well. And with any of our player data, obviously it has to go to a upper level with the NBA, but I think we'd love to explore it because obviously we want to keep our guys playing. So let's keep talking.
Fantastic. That'd be great. That'd be really good. Yeah.
Hey, Peter. I have a quick question for you, sir. This is Cruz Romero with the Phoenix Suns.
Hey, Chris.
Do you have any comments on surgical techniques, any pearls that you have there? And then also curious about your general thoughts on BFR throughout the rehab process.
Yeah, really good questions. With the first one, I don't, I, I'm not aware of any strong evidence to say this surgical technique is better than that one. There are quite a few things that are looked at, and obviously things that have been very well documented in the literature, like speed bridges and things like that. But there's not any strong evidence. So it does come down to the surgeon, their preferences, and what is really going on at that point in the orthopedic circles. But my strong thinking is that my strong hunch from the experience we have with these is that if you do good rehab, it doesn't matter. It probably doesn't matter. You can still get a really good outcome. And always with the surgeon, we talk about just make it as tight as you can. Because if you make it tight, it's going to be a better outcome, because you can always lengthen a tendon. You can't make it, it's harder to make it shorter. So that's what we talk about with the surgeons that we work with here, as something that's a good thing to aim for. What was your second question? BFR.
BFR. Yep.
BFR. So BFR, it's something that it could be useful in those early stages. To be honest, we don't use it a lot. We do use a bit of Compex for some people. So we put the Compex on in those really early stages when they really just cannot feel their calf, or it's just not activating. But we haven't gone to BFR, but I think it could be something that is an additional add-on and that could add some value in those early stages. Yeah. And again, I'm not aware of any sort of research evidence looking at it, but it could be valuable.
Awesome. Yeah, that's great. Thank you. Appreciate that.
No worries.
Aside from Compex, do you use any other modalities?
When you say modalities, what sort of things are you thinking about there?
Laser, hyperbaric, all of that stuff.
Yeah. I think, look, there's a real strong place for recovery. So if you can maximize all the basic recovery elements, I think that is going to be a really positive thing. The other thing I go to is collagen supplements. So definitely get them on collagen supplements. But I think pretty much everyone is on collagen supplements now with any tendon problem or Achilles problem. If you have access to hyperbaric, laser, then why not? It's not going to harm, and it could be helpful. I don't see any reason not to, but it's not something that we have as part of our protocol per se, but it could be an additional thing that is added on. And especially with these high profile people where it is expected that they've got 24 hours a day to spend on recovering their tendon. They're going to do as much as they can. It was interesting to see the documentary from, I forgot his name now. I've got a photo of him here. The New York quarterback. What's his name again? Aaron Rodgers. Yeah, that documentary where I think they probably did really good stuff with him, the medical team, but the documentary focused on stuff that was just peripheral to the stuff probably going to get him better, which is, as we know, the loading. And I'm sure that was not the truth, because it was just a documentary trying to focus on things that were a little bit different, but yeah, it didn't paint a very good picture, because it did focus on those more peripheral things. But I think those peripheral things are fine as long as they're within the package of everything you're doing.
Do we have any other questions?
I'm just going to say, just quickly, my email's here. So if there's any questions, if people have any questions, just let me know. And I'm happy to share these slides by PDF with people. Okay.
Yeah, that would be great. Peter, thank you so much for your time. I know we ran a little over here, but I know everyone on the call really appreciated it. It was fantastic.
No problem at all. Happy to help, and thank you again for the invitation.
Yeah, we'd be happy to invite you again.
Yeah, no problem at all. No problem at all. Thank you very much. Thank you very
Okay.
much, guys.
Thank you so much.
Thank you.
All right, no problem at all. Have a good evening.
Thank you. And thank you, Nick.
Thanks, guys. Thanks, everyone.
Thank you.
Have a good
Thanks,
evening.
Nick. Thanks for
you.
organising. Thanks, everyone. See ya.
Bye.
Bye.
That was great.